Hello, everyone. Welcome to the Reframing Podcast. Today's guest is Dr. Dave. She works in Buffalo. Welcome to the podcast.
Thank you so much for having me, Maria.
Yeah. So she was an academic scleral lens specialist that transitioned to ocular surface disease and just does that right now at her clinic. So I wanted to have an expert on to kind of talk about ocular surface disease and all the different things that we might see in our clinic that we can get some information from her today.
You got it. It's going to be a fun conversation. I'm looking forward to it.
So I just want curious, how do you transfer over from scleral lenses to ocular surface?
Yeah. So when I practice at the University of Buffalo, so it's an ophthalmology department mixed with optometrists and ophthalmologists. And when I was first recruited over, they needed somebody just to do sclerals. And when you think sclerals, immediately the first thing that comes to your mind is keratoconus patients or refractive patients. And what I started realizing was there was a niche of patients that not only just had dry eye disease, but had graft versus host, Stevens-Johnson's, pemphigoids. And a lot of these patients started coming into my practice. I was fitting them in scleral lenses, but then that was it. They had nobody else to really support them through their ocular surface. They'd get bounced around between different subspecialists. And so that's what really kind of drove this niche of wanting to focus on ocular surface disease, which is a really broad term, right? Like, what is really ocular surface disease? It's beyond just dry eye disease. And I think what's been fun in the past couple of years is to bring in new technology, procedures, bringing in new diagnostics, but most importantly is collaborating with other professionals, not only just in the eye care space, but also in medicine overall. And I think as a whole, what that's really doing is elevating our profession, but providing patients a quality, comprehensive care so that these patients don't feel like they're just getting bounced around.
Yeah. A lot of doctors ignore dry eye, but I think it's pretty simple to diagnose and treat, and we should be treating it. What are some actual driving, factors that, ocular disease we see in most of our patients?
Absolutely. So I think that the key here is that if you look hard enough, you're going to find some level of ocular surface disease in any patient, right? And you don't need really fancy technology. I mean, is it nice to test for osmolarity and meibomian gland imaging? Absolutely. But if you don't have that, doesn't necessarily mean you can't treat it. And so for me, it's use your stains, use your lissamine green, your fluorescein, look at blink quality. Don't ignore the lashes. Don't, something as simple as just palpating the lids and seeing how's that apposition to the globe, how are the meibomian glands expressing. And slowly as you look for a lot of these findings on the slit lamp, then there you have it. You can at least find some level of tear film abnormality, lid abnormality, corneal abnormality too. And I think what's important is that people need to realize that treating dry eye and ocular surface disease is part of primary eye care, right? You don't need to skip beyond, it's great if that's what you want to do all day, every day, but in a primary care space, it's really important to address that. And if you don't have certain technology or treatments available to your patients, then hey, this is where you get to collaborate with your colleagues from down the street.
Yeah. I have patients that come in, some are, have terrible symptoms, minimal staining, others don't. Mm-hmm. How do you treat that? How do you have troubleshoot for that for some of the doctors?
Absolutely. And you can usually find those patients when they come in with their bag full of drops and they're like file folder full of like, I've tried everything, right? And I think the key here is not to treat every patient as the same. Really treat the patient and not just their symptoms. So for you patients that have pain but no stain, start teasing out some neuralgia symptoms there, right? I use, honestly, the proparacaine test or challenge as a really big marker for understanding where this patient's going to be successful. So for those that are not familiar, the proparacaine challenge test is to put in a drop of an anesthetic in one eye or both eyes and really just assess the patient's overall symptoms. If they find immediate relief, you know that treating that ocular surface from a dry eye standpoint is going to be beneficial. And that includes, in my world, scleral lenses, right? But if that patient's not really having relief, they still have their residual symptoms, the burning, the discomfort, the aching in the eye. Well, this is where you need to really think about co-management on their central nervous system and thinking about pain management from an oral perspective as well. So those are your patients on the pain spectrum. Now, the patients that cornea looks not that bad, or sorry, cornea is staining, it's glowing up, but they're not feeling that bad, right? They're kind of shrugging their shoulders saying, Doc, I'm fine. Well, those are your neurotrophic patients. And something as simple as dental floss or a con-wisp and checking that corneal nerve sensitivity is important. I reassure this to all of my residents too, is that you want to make sure you do this after, if you have staff that does diagnostics for you, if you've got staff that's checking IOP for your patients, don't do it on a day where your patient's already numb, right? Because of course they're not going to feel anything. But the other aspect too is to check all 5 aspects of the cornea. It's not just central cornea, but looking at the 4 quadrants. And you'll be surprised to see not only asymmetry in one eye compared to the other, but also you'll find that a lot more patients are desensitized on the cornea than you're used to seeing, and it helps you gauge. And I don't have an aesthesiometer in my practice. I just use my, subjective findings as a way to really gauge how to treat that patient. And we obviously have therapeutics that help with that, but an arsenal of a lot of other options for optimizing the ocular surface too. So I just had a patient earlier today, glaucoma patient on a plethora of drops, and coming to see me because she has no pain, but that surface, it literally looks like someone took sandpaper and scraped it all over her eye. And glaucoma really wants me to see if I can help with the scleral lens and optimize that surface. And the first thing I did was I checked her corneal sensitivity. And of course, it's absent. So that helps me gauge what therapy to go down. And it doesn't mean a scleral lens may not be a therapeutic, or I may not think about optimizing her tear film through other, immunomodulators. But my first step here is to say, are the nerves working? And so that's a really long-winded answer, but I think the goal here is every patient's going to be different. So get to know your patient and then assess your treatment plan accordingly.
Yeah, I mean, if you had a patient that couldn't feel a cornea, now you solve their problem, and now they say, "Hey, it hurts." Well, that comes up a lot. How do you explain that to patients that we're really are helping them with this new treatment?
Absolutely. I think photography goes a long way. I like using slit lamp images because it allows a patient to kind of turn their chair around and see what I see. So that's number one, because we can see if corneal staining is improving. That's a reassuring thing for a patient. 2 is visual acuity. A lot of these patients that have very poor surfaces will complain about fluctuations in their vision. And as the surface optimizes, they'll notice their acuity is better. But then the big problem is now they're feeling symptoms more, right? They're burning, they're reactive in terms of tearing. And my response to that is, that's a good thing. We're finally getting you down to normal. And at some point in time, we'll expect that trigeminal nerve stimulation to normalize. But it's an exciting idea to know, okay, yes, finally now you can feel things. And I oftentimes have patients post-treatment for neurotrophic keratopathy ask me, can you check my nerve sensitivity again? Because it's a marker for them to feel reassured that this treatment is working. And that's also an adjunct with their symptoms as well. So it's all about how we present it to patients. I think as eye care providers, we have to be good communicators, right? We can't just throw a bunch of drops or treatments at patients. And I think being able to work with your patient along the course of therapy and reassure them, whether it's through diagnostics or photography or just even this conversation, it goes a long way.
Yeah. And there's a lot of different new drops that have come out. So doctors are like bombarded with all these things. Like, how do they know which drop to RX? Whether it's an anti-inflammatory, whether it's MIBO or new Tripty or things like that. How do doctors know which ones are going to work, or instead of just kind of throwing things at the patient?
Yeah, throwing the whole kitchen sink at them. And that's where I find that we lose faith in a lot of therapeutics, right? When you just, this drop doesn't work and let's try another one. And I think that the goal here is we're lucky that today, you think back to when Restasis first came out, that was like over a decade ago. And we're lucky we have a lot of options, but the goal here is when you're prescribing, it has to be intentional. So if you have a patient with a high osmolarity, you're going to want to bring that inflammation down. And that's where using maybe a short-term course of a steroid and one of the immunomodulators might be beneficial. But if I have a patient that has a really low tear meniscus or a low Schirmer's, well, I'm going to think about using a therapeutic agent that's going to stimulate more aqueous production. If I have a patient that has just low tear breakup time and really needs to stabilize their tear film quality, number one, we got to look at those glands, right? We have to use what we naturally have, but then we can use, perfluorohexyloctane as an adjunct to that too. So I think the goal here is using each of your diagnostic tools or clinical tools to understand what is the driving bus for the ocular surface. And what we know about a lot of patients is it's mixed, right? Sometimes patients will need multiple therapeutics to optimize, and this is where then you use your clinical judgment as a provider. The one thing I'm not going to ignore is the fact that insurance unfortunately drives a lot of this decision making too, right? What can we actually get access to for our patients, and what's going to be cost effective for our patients? And that's something that is important.
Yeah, I think a lot of doctors, kind of shy away sometimes just because of authorizations, and they know that things aren't going to be covered by insurance, so it's just a little harder in that aspect.
Absolutely.
I think lids have a lot to do with dry eye. Let's talk about that. I'm sure you take a look at the meibomian glands. I think take a look at blepharitis, lashes, things like that. Let's talk about that because that's been a big change over the last couple of years in the industry, and I see a lot of patients that come in with Demodex blepharitis.
Absolutely. So I'm going to actually take you back a little bit. For those of you who don't know, I'm Canadian, and so I used to practice on both sides of the border, and I was lucky in a sense of having access to some pharmaceuticals and therapeutics on one end and the other. And where intense pulse light and radio frequency really came to fruition was in Canada. At first, I had access to it. It was Health Canada approved before it even cleared the FDA in the US. And what I found was that when we look at the lids, number one, we got to look at that inflammation in the lid wiper. Two is we're looking at telangiectasia, right, and rosacea findings. Three is, do you have glands, number one? And if you do they express? And then fourth is, of course, the organisms that live on our skin, including Demodex and staph. And I think that the importance of what I see now is that we have procedures to really optimize lid anatomy, but also the status of the lid. So having lotilaner to calm down Demodex is helpful. Having telangiectatic vessels and really regressing that ocular rosacea through IPL is helpful. And last is when you have meibomian glands, well, we want to express them, and whether it's thermal pulsation device or radio frequency, well, we can get those glands working. And my, discussion with patients is we have a lot of therapeutics that can replenish what your body is missing. But if we can use these procedures to really get your body to kickstart what it naturally needs and should have, then I think it's a great marriage of the two. And that's where we can optimize a lot of ocular surface disease.
Excellent. A doctor that's starting off just a slit lamp tear breakup time, what's the first piece of equipment would you tell them to purchase to kind of get started?
I personally feel like a really good slit lamp optics, and not only fluorescein, but lissamine green. I find lissamine green is oftentimes missed. A lot of doctors don't even have it in their office. The reason why I think it's important is because beyond just looking at corneal staining, we need to pay attention to conjunctiva, right? And dry eye disease is not just isolated to the cornea, it's also the interaction of the lids with the ocular surface, including the conj. And lissamine green is a very powerful tool to be able to look for lid wiper epitheliopathy, to look at conjunctival staining, even caruncle staining that can open up this window into thyroid or other, systemic diseases too. Beyond that, I find slit lamp photography is very helpful, not only in monitoring patients, but also educating patients. At that point, if you're ready to level up, that's where then you'll want your Schirmer strips, your tear film osmolarity device, your, meibomianographer. I think that's the bare bones. But I think starting off with just some really good stains and a great slit lamp exam is all you really need from a primary care perspective.
No, I agree. And a lot of doctors have asked, like I said, start off basic. And that's how I've done it in my practice. I mean, we're not a big practice like yours for dry eye, but it started like that and made sense business-wise. So I bought that, level up, did that, and then bought an IPL when I had the patient base and did that. How do you use IPL? Give us some information on that, because a lot of doctors are interested in it and might not know how to approach patients with it or how to kind of, get the patient to opt in.
Absolutely. So I think the IPL technology is really valuable for any type of inflammation, obviously on the lids. And my big marker is if I see any type of telangiectasia on the lid, then that's already a conversation for it's too far gone and you really need IPL to regress some of that. But I started having this conversation really early with patients when I started seeing facial rosacea. And that I can pick up from just walking into the room and seeing what the patient's cheeks or nose look like. And it's interesting, right? When you bring up that conversation of rosacea with patients, they'll look at you oftentimes and say, no doctor's ever said that to me. Or I get the opposite of, oh, I see dermatology and I use lotions and I'm fine. Or every now and then you'll see a doxycycline on the med lists. And so I think it's really important as eye care providers to educate patients on if it starts here, it's eventually going to grow up here. And what are the consequences, right? What are the consequences of having red, meaty, hot, angry lids? What is that doing to our meibomian glands? And what's the end sequelae? It's going to ruin your ocular surface. And so if I can educate patients on it right off the bat, I oftentimes will say to patients, you may not need it now. You may not want it now. You may not be able to budget for it now. It's not covered by insurance, but let's plan. And I find that that discussion doesn't only happen in one visit, happens in months, oftentimes years. And by the time that we do feel like it's time to pull the trigger for IPL, patients are already bought in because they've been educated along the process. Yeah. The flip side of it, I think also is important, is working with our dermatology colleagues, right? A lot of dermatologists either know about IPL and feel like it doesn't necessarily help, or they don't really understand the correlation it has with dry eye disease and ocular surface disease. So that's something that I find from a co-management perspective is very helpful. And I'll send a lot of these patients back to my dermatology colleagues if I choose just to treat, on label, that they can work on other aspects of the face and use that technology elsewhere. And if you in your practice have an aesthetics component where you're treating facial rosacea overall, well, that's another stream source of referrals that you can get from dermatology as well.
Of course. Let's talk about other procedures. What other procedures can optometrists do for dry eye, lids, things like that?
Absolutely. So number one, we talked about blepharitis, and we're lucky, obviously, if Demodex is an etiology, we have a therapeutic for it, but it's more than just Demodex, right? You can have keratinization and lipid buildup on the lids. And so I love having microblepharolar exfoliation devices in the office. There's many devices in there. There's many solutions. Pick your adventure and what suits you. But I find that that's a very nice tool to have patients come in on a sequence basis. And I describe it as like your dental cleaning, right? You think you're cleaning your lids and your lashes a certain way at home. Keep up with flossing at home, but we're just helping supplement along the way. Getting rid of a lot of that keratinization really just helps to open up the meibomian glands. I really enjoy meibomian gland probing, especially when you've got meibomian engraphy, where you can see some of those glands are truncated and fibrosed. Going in with that probe and really just opening that up and opening up the piping really helps to improve gland expression. I'm a big believer of radio frequency, not only to melt the glands, but there's an aesthetic component of the collagen turnover too. And patients appreciate that, especially when we think about how different the skin is around the eyes. And then, of course, your muscle stimulation of your periocular region, right? And there's devices to help tighten that up. Why is that important? Is because we need the windshield wipers, the eyelids, to actually close, right? And if the lids don't close, or they're not abutting the globe the way they should, well, now you've got exposure, you've got floppy eyelids, and also from an aesthetic standpoint, patients aren't happy. And that drives again into ocular surface disease. So those are the different categories of dry eye procedures. We can't forget about our thermal pulsation devices as well. But again, it's not something you have to offer to every patient. Maybe you can co-manage with the optometrist or ophthalmologist down the street who has the investment in this. I think the goal here is just to understand what patient would benefit from these procedures, and then you plan accordingly.
Yeah. No, that's great information. I mean, I've never done probing. Can you give us like a little bit of information on that? And
Sure.
Doctors kind of want to try that. How, like, what is like from the beginning to the end kind of look like?
Absolutely. I'm going to admit the probes currently are in back order, so I haven't probed in a while. But there is a specific technique where you're going to image your meibomian glands, and we can see how many glands exist, whether it's 20, 30, 40 on your lid anatomy. And the goal here is you're going to use a filament. I typically start with the 1 millimeter filament. That's essentially you're going into the orifice of the meibomian gland and then basically pushing the probe in. And until you feel resistance, and you probe all the way through and pull it up. You may get a little bit of blood coming out, especially if you've got telangiectasia on the lid margin. But the goal here is that you're just really opening up the piping essentially a physical kind of obstruction of the gland that you're opening up, and then allowing the meibomian gland to turn over to produce the meibum and express that out. I find probing works very well initially, and then maintaining some type of thermal pulsation device and or radio frequency just to get that gland to express and get all that buildup back out. You can have filaments up to 4 in size. I've never personally used one, but I know colleagues in the profession that have, and all the power to you for that.
Excellent. Let's talk about systemic diseases and avoid, like, if a patient comes in, they have a systemic disease. When do you start looking for dry eye and things like this with telangiectasia, lid issues, things like that?
So what we know about all of the systemic diseases that create inflammation, right? Whether it's rheumatoid, psoriatic, lupus, sarcoid, thyroid, those are the ones that as comprehensive eye care providers we know about. The ones that I get a little bit more curious about are those underdiagnosed Sjogren's patients that we know not only have just ocular findings, but they also have other systemic issues, whether it's inflammation or even dental issues too. So one thing that's been very helpful for me to build in my clinic is if I'm suspicious of a patient that has Sjogren's, I send them for lab work myself. And that lab work is not just limited to the SSA and SSB antibodies, but I run a Quest code that's the early Sjogren's profile that looks at some salivary proteins as well. And if that blood work shows anything that's tangible, then that's when I'm working with rheumatology directly to have that patient established. But then that third piece is connecting the patient with a good dental colleague too, right? Who's paying attention to the dryness, not just prescribing oral pilocarpine and saying, send them on the way. Our dental community also has low-level light therapy and other procedures to stimulate the salivary gland. And I find that my Sjogren's patients, when diagnosed, are very appreciative of that kind of team approach. They feel like they're taken care of. They feel like everyone's communicating. And not only that, from a business standpoint, it's a great referral source, right? All patients talk to one another. The other piece of it that I always think about is patients with dermatology issues beyond just rheumatoid arthritis or ocular rosacea or psoriatic rosacea, but dermatology issues that can present in lid abnormalities too. I have a lot of patients in my practice that have Stevens-Johnson syndrome. It's an unfortunate acute condition. And a lot of these patients found their way to me because of scleral lenses, but then their surface still needs to be managed. And so I find a lot of these patients between my clinic and oculoplastics really benefit. The last one is graft versus host disease, which, a lot of oncologists will be very aware of aggressively lubricating those patients' eyes. And if those patients are lucky enough to find a cornea clinic or a dry eye clinic, but a lot of graft versus host patients will go through flare-ups and they don't even realize that they have flare-ups until you see them and their eyes are beet red and nothing has really changed, but I forgot to take my oral prednisone, or I had a change in my systemic medication. And this is where I think as eye care providers, it's very unique. We can advocate for these patients when they're suffering from chronic conditions. And so those are examples of more of a smaller cohort of patients, but definitely necessary as eye care providers to help support them along the way, not only with our dry eye tools, but communicating with our colleagues in medicine.
Yeah. Well, thank you so much for coming on the podcast, talking about dry eye. I mean, you're very passionate about it. It's very evident, and it's great for the listeners to get this information. I know I learned some things to incorporate into my practice and to help our patients, right? So thank you so much for coming on, and I'm sure you lecture at a lot of conferences. We'll probably learn more from you at any conference this year. Are you speaking this year or?
Well, I'm on the conference tour, so I'm sure major conferences. I'm happy to meet the listeners, both in person and hopefully virtually. And I'll end it, Maria. Thank you so much for having me. I find that as optometrists, we lose the zest of refracting and looking at OCTs. And while that's important, I think what's really important about ocular surface disease is we can make a difference in patients' quality of life. And when you know that you're impacting the way the patient's feeling, the way they're seeing, the way they're living, it makes you sleep better at night. And I think that's why I'm so passionate about it.
Yeah, it's a rewarding profession, and we like what you do, right? So
exactly, you have to.
It's very important.
It's so true. Well, thanks, Maria. Appreciate you having me.
Does anyone want to reach out to you? Is there an email address they can reach out?
Most definitely. It's going to be avnidave@gmail.com, or please connect on LinkedIn, and we'll be happy to continue this conversation.
All right. Thank you so much.